Hello, everyone, and welcome to this week's meeting for the Rotary E-Club of Silicon Valley. My name is Cviatko Shirov. I'm the president of this Rotary Club. And today, like every week, we are bringing you a new inspirational speaker that's going to talk to us about a very interesting topic. Like always, we try to focus our presentations on education, entrepreneurship, and innovation. And the speaker that we have for you this week is Ruth Verhey. And Ruth is a PhD, holds a PhD, and she's a senior clinician at the Friendship Bench program in Zimbabwe, in Harare, Zimbabwe, which is where Ruth and I met. And she has research interests in PTSD, HIV, common mental disorders, and she's currently the co-principal investigator of the Friendship Bench research team. And she has some previous published work related to mental health services. And she has focused most of her research on sub-Saharan Africa, especially Zimbabwe. And most of her research has focused on persons living with HIV. And in addition to all of that, she's also working as psychotherapist in Harare, Zimbabwe. So with that, I will hand it over to Ruth. Ruth, take it away.
Okay, hi everybody. So I would say good evening, but for many of you it seems to be day, good morning, I don't know. So I will share my screen now to start my presentation. I'm very happy to be with you. Let me just get this working. Here we go. Okay. Can you see my screen properly?
Yes, perfect.
Or is it? Yeah, okay. Oh, now it's better, I think. Wait, okay, I'm learning. Here we go. Okay, so I'm going to talk to you about the Friendship Bench. And the Friendship Bench is... yeah, now my slideshow doesn't work. Oh God. Okay, wait a minute. Is that all how it works? Yeah. Slideshow gone. Here we go. Okay, here we go. Right, here we go. So just to locate where Zimbabwe is for everybody, it's in sub-Saharan Africa. As you can see, that green little country, which is surrounded by South Africa in the south, Mozambique in the east, and Botswana and Zambia in the west and kind of northwest. And we have about 15 million inhabitants here. And we have found in previous studies that there are people who come to primary care clinics, which is the majority of the population. As you can see, at the moment, we're looking at 60% of the population being below the poverty line. So 30% of those people who come to primary care clinics actually have symptoms of what we call common mental disorders. That's the CMD. And common mental disorders are depression and anxiety, but also PTSD and can be substance use disorders, for instance. So as you might have heard, sub-Saharan Africa is the region in the world that is most affected by the HIV epidemic. The current prevalence in Zimbabwe is about 13%. And we have a stunning rate of 84% of those who are tested being on antiretroviral treatment, which is really great. Nevertheless, we found that people who suffer from depression, for instance, have worse medication adherence, which is a huge problem in people who live with chronic illness. So what is the Friendship Bench? So the Friendship Bench is a very low threshold psychological intervention. We basically offer problem-solving therapy, which stems from cognitive behavioral therapy and is like tested throughout the world. And we have come up with like a cultural, acceptable and easily accessible version of it. So we have local terms in our local language for it, and people really sort of buy into it. So we are working with a task shifting program, and that comes from being a low-income country and just not having enough mental health professionals. So task shifting basically means that lower cadres are specially trained to take on jobs, and they've got supervision by higher cadres. And this has been very very successfully used in a lot of the low-income countries in medical settings and all sorts of settings. And we, like I said before, we address common mental disorders, and it's all happening on a primary care level. And you will see just now, it is literally happening on a bench. So in this photo, you see me, and you see to the right, you see Dr. Dixon Chibanda, the founder of Friendship Bench. He's a psychiatrist, and he did his MPH in 2005 or something, and he had to do a field work. And because he's a psychiatrist, he thought, let me measure the prevalence of depression. And he came up with these, well, he found this very high prevalence of depression and nothing in place for it. So not only are there mental health professionals lacking, even and also in the primary care level, there's just nobody who can do, who can offer mental health care for people who need it. And here in front, this is Melania, one of our lay health workers, as we call them, or grandmothers, as the media coined them lately. So we did a very successful trial in 2015 that was funded by a Canadian donor, by Grand Challenges Canada, so Canadian tax money, thank you to Canada. And we did this trial, and we found that our intervention was actually extremely successful. So you can just see here, like it was a randomized control trial, and the key results are very clear, as in the blue ones would be the control, and the orange bars would represent the intervention participants. And we did a 6 months follow-up, and there was like a significant change in the prevalence of common mental disorders. Or to the right, it says PHQ-9. This is a diagnostic tool called Patient Health Questionnaire from the World Health Organization. And you can also see, just see, you know, you can read our paper if you want, but you can see there were significant differences between those people who received the intervention versus those who were in the control, where basically we called it like treatment as usual. So basically they didn't get anything. And then we also looked into, we need to scale this up. Obviously, because there's such a lack of mental health specialists, there's such a high need for it. The nurses who run primary healthcare clinics are like overloaded. And to put it in context, in our setting, the word for depression in our language here is translated into English as thinking too much. So in Shona, it's called kufungisisa, and in English, it would be the thinking too much. So you can very easily imagine how people who are thinking too much would sort of feel a headache, right, and present with a headache to a clinic. And if a nurse then doesn't have any skill set or experience or training for mental health, she would probably, or he would probably, give a painkiller. And that's what happened a lot in the past as well. Now, luckily, what are we, like 12 years down the line, 13 years down the line, we're actually really successful, and people have huge amount of awareness of mental health. So why we scaled up is because of the high demand, what I just said already. And since March, we're also part of the National Mental Health Strategy of the Ministry of Health in Zimbabwe, which is really exciting for us, which basically means we've got the mandate to roll out in the whole of Zimbabwe. At the moment, we are in the whole of Harare in all primary care clinics, and in 2 other cities. One is called Chitungwiza, which is right outside of Harare, and another one is called Gweru. We're preparing to not only go nationwide, but to go global. So we are already in Malawi and on the island of Zanzibar, which belongs to Tanzania. And I don't know if any of you read the New York Times a couple of weeks ago. We are also in New York. So that's something quite interesting. So the former New York Commissioner of Health had actually worked in Zimbabwe many years ago, and she had somehow remembered about the Friendship Bench and brought that in, and that's going really, really well. So that's quite exciting for us. This is just to give you an impression. So why is it called the Friendship Bench? Because literally we're using wooden park benches, and you can see this wooden park bench being placed outside a clinic setting. So when my colleague Dixon started this, basically people were quite receptive and said, yes, go ahead, do it, but we don't have any rooms for you. So the only option he was given was to put benches outside the clinic house or the houses. And that's basically what we still are doing. And you can see in green here one of our grandmothers. So this also speaks for itself. A lot of people ask us, why are we working with elderly women? And the answer to that question is basically, it was a bit of a coincidence, because these were the cadres that were available to be trained to do this kind of work. So nurses were overworked already. Other people had like very distinct jobs and had no place to take something on. But these lay health workers, or health promoters, as they're also called, are employed by the city health authorities, and they have that task to basically go around and do health awareness campaigns, as in they would move around their communities and alert people to cholera or to vaccination drives, etc. So for them, they were the right cadres. And now we're looking back and we're thinking, that was so good that we found these women and that we were allowed to train them, because they have this, what we call like this wise woman label to them, of course. And in our society, people are also very aware of the elders having knowledge and being respected and being authority figures. So our grandmothers are totally able to wander around their communities, which they live in as well, and go to people's and into people's houses as well, and literally tell people, you will come and talk to me now, or you will come to the clinic and get tested for HIV, you don't look good. So that's very important for us, that we're actually working with women who have access to the community, because we want to be, and we are, a community-based program. So here you can see Dr. Dixon Chibanda in the middle of them. So we're trying to meet often with them and give them supervision and support. And we have found that over the years, those grandmothers have learned an enormous amount and have become better and better. So a little story, for instance, is in the beginning, we were very careful of teaching very well how to assess for suicidality, for instance. So basically to learn how to ask someone whether that person has suicidal thoughts. And there's often myths, and I think that is worldwide, that people think if I ask someone about whether they have thoughts to kill themselves, they will do it. And it's very important to bust myths like that. And at first we thought, oh, maybe the grandmothers can't handle it, then just have to refer immediately to a tertiary institution like a psychiatric unit. And now we're looking at them in the reports, like when we look at client data, that actually they're managing these kind of clients really, really well themselves, which we believe is just through that fact that they don't get freaked out. They sit, they listen, they've got all the patience of the world, and they've got that determination to make this person feel better. So part of the friendship bench is also a group, a peer-led support group, which we call the Circle Kubatana Tose, and Kubatana Tose stands for holding hands. And that is also our income generation component, because as you can imagine, a huge amount of people have little to no income, or no regular income. So this came in quite interestingly. So as you can see here, the hands of one of my colleagues who's crocheting a bag out of, these are old VHS tapes. Here you can see another photo of women sitting together and men. Someone reads a newspaper. So the peer-led support group is a regular meeting place where we make these bags together. And this is sort of not very directed, like they can make their bags the way they want, but it was this therapeutic effect of sitting together, sharing stories in a safe place, being through the intervention together. Well, having been through the friendship bench intervention, like all of them, not together, but all of them. And so knowing about depression, knowing about anxiety, knowing about getting better and what it feels like. And so we have found that this is very helpful. Plus, we always hear stories of women then saying, I had no money, I didn't know how to feed my children, I was really like not knowing where to go, and then I sold a bag and we had some food. So just another one. I just thought it was beautiful to see these women laugh together. There are men in those groups. In general, we have found that in our trial, we found that as well, that about 80% of those people who come to primary care clinics are actually women. Partially that is because women in the reproductive age, of course, will go there with children for themselves because maybe they're pregnant or they're whatever, postpartum or something. And men rather have a very shocking health-seeking behavior, which we are worried about. And that's also a public health threat globally. So that's something we always have to work about and we work on. And we were very excited to see that men were extremely happy to come to these groups. So we can just hope that from now on, as we have one project actually where we work with young counselors, so not grandmothers, but actually students on attachment who stay a whole year with us at Friendship Bench, and we've trained them in the intervention to attract more young people and also especially young men, and that is going really well. So watch that space for our publications coming out. So the sustainability, of course, is a very important part for us. So people often ask us, how is this paid for? Do you need donors? What, I don't know if you know much about like low-income countries and donor-driven activities. I think in Zimbabwe, about 75% of all the medical, using my English here right now, of all the medical concept is paid for by donor money. And we are lucky that our lay health workers, our grandmothers, are getting this stipend, this little regular money from the city health, which makes our project quite sustainable. What's interesting about them as well is that they live in the same communities that they work in. And I was personally very interested in their own mental well-being, because my hypothesis was that they might be quite affected by the stories they hear and being exposed to the same kind of challenges and living in the same kind of community and seeing the problems that Zimbabwe faces directly. And surprisingly enough, they are extremely healthy, on the measures that we took with them. Like we looked for depression, anxiety, PTSD, and post-traumatic stress disorder. And we're very happy to hear and to see that they seem to be very resilient and strong. And one explanation for that is surely that they have this huge recognition in the society and that it just gives them a sense of purpose, which I think we all can agree with. If we help someone, we all find purpose in that and we find hope in that and we feel better. So like the way they describe it, it's a very fulfilling job that they're doing. Interestingly enough as well, they're not only doing Friendship Bench, as I said earlier, they do their other work as well. Yet they said to us right away that they managed to integrate this new skill, this problem-solving skill, with their other work and say their other work is now going much better for them. So I can talk much more, but I think I would stop the presentation now. I'm not quite sure about time, and then we can maybe start the questions.
All right, great. Thanks so much, Ruth. It's always so cool hearing about the Friendship Bench, and I really like your model of intervention and the communities, and really the way that you are mobilizing the older women who are so respected traditionally. I think it's so very important. So thank you so much for this presentation. Very, very cool. So before we move to the Q&A, I'd like to introduce the other folks that we have on the call here. Let me just switch this to gallery view. There you go. So I'm going to start with Roger from Canada. Hi, Roger. Wave to the camera there. There you go. So Roger is one of our Canadian members. He's from British Columbia. He's the head of our programs committee as well. So thank you, Roger, for your leadership there. We also have Nick, also from Canada. Hi, Nick. There you go. Verheen from the Silicon Valley. Hi, Verheen. And we also have Shags there with his pictures in the back. Thanks for being here, Shags. All right. So Ruth, a very cool presentation. I think I have a couple of questions on my own, but let me start by seeing if any of the folks that we have on the call have questions that they want to start us with.
Not a question, just a comment. It's amazing work, and thank you so much for bringing it to the world.
Thank you. Thank you for listening.
Right,
I do have a question around you kind of stumbled into, you were saying how it was a coincidence that you got the grandmothers to be your person on the ground. When you are looking to go to other places where that person might not be the same, have you identified, like New York City, for instance, is there a particular person that fits differently?
Okay, so what we have figured out, what works best, especially in the mental health context, is people with lived experiences. So someone who's had depression will understand much better what's going on. And if you look at like the WHO prevalence for, like, lifetime prevalence for humans in general, it is like 25%. So 1 in 4 people will experience depression at some stage in their life. So that makes us a lot of us will know what we're going through and what we have gone through and what others can go through. And so in New York, so they, the way I understand what they're doing there is because obviously in the States, you have all these amazing referral points and agencies that help and stuff. So a lot of it is just talking, connecting, getting someone to open up and trust someone else and feel, wow, I'm a human, I'm a normal person, someone actually listens to me, and then being linked up to whatever help agency there is, you know. Whereas here for us, we obviously don't have all these nice help agencies, but we have someone who just also listens and takes that time. And I think that comes across a lot, that these grandmothers, well, they have a lot of work, but they still have that time. And what we're only kind of learning, the more research we do, is that it's not just happening at the clinic on the bench, you know, because if that grandmother goes home, it's probably going to be her neighbor 3 houses down who's going to say, hey, we've talked last week, can I just chat to you over the fence, you know? So there's a lot of interpersonal contact that just carries on, or it's maybe at the borehole. You know, a lot of us don't have running water in the house, so people would go with a bucket to somewhere to get water and wait in line. So and that's, for instance, something that I was surprised as well. These groups where the women make bags, they've also spontaneously helped themselves standing at that borehole to get water, for instance, and help each other keep the space or keep it safe. Or they do these mini lending schemes where everybody would give $1, and this week Nick gets the $1, and then we all give $1, and next week Fahim gets the $1, you know, and that makes a huge difference in our environment. Huge. And of course that's all based on trust. Even if it's such minimal amounts, it all only works when people trust each other. And I think that makes a huge difference. Yeah. So unskilled people, totally just people with a heart, and people who sort of know what they're talking about in a way, you know? Yeah. Sorry, it's so long.
Oh, go ahead, Roger. Yeah.
Roger, go ahead.
One question for you. In Zim, what is the life expectancy for men and women?
Ooh, I would have to look that up, but it wouldn't be, it's not as high as in your country. I would guess probably around 50 something, between 50 and 60. And that is due to hard work, high prevalence of chronic illness, you know, even like medication resistant TB is quite rampant here. So yeah, let's look that up though, but it's not as high.
Google
as in first
Okay,
world.
the reason I'm asking that is because my wife, and what she does is she works in mental health and addiction here in Kamloops, and she assesses seniors for long-term dementia and Alzheimer's and those types of things. And quite often what they do as part of that program is differentiate out depression as a different diagnosis. And that's why I asked the question, because most of my wife's clients are well in their 70s and 80s. So it seems that in your environment, in your country, that you just don't have the prevalence of that, the seniors that we have in our society.
Yep, I think you've got a point there. Nevertheless, we also have cases of dementia. It's just because of the whole under-resourced medical system, it's not been anything that people have looked into. But I think it happens now a little bit more because it becomes a problem and people have to look after it. And also put it in the picture of a country like Zimbabwe always suffers from brain drain. So a lot of the young, well-educated people just leave for greener pastures somewhere else, which also means the sort of the original, like, big family looking after their elders sometimes just falls apart because someone has to go to the diaspora, how we call it, to send money here. It's like a lot of people, a lot of families survive purely on someone working in the US, in Canada, in the UK, in South Africa, and sending money home. So yeah, but it becomes something we will have to look into much more. You're absolutely right.
Farheen, go ahead.
Thank you. Real quick, so that statistic this is actually pretty wild. So apparently in 2006, the life expectancy was only 37 years. But then now, like about 2017, I found this article, it's about 59. So thankfully it's shot up, in the 10 years, but wow, from 37. So that's pretty wild.
That is because of and partially it's because of the introduction of very powerful antiretroviral medication.
Yep. That makes a lot of sense.
So much less young people die, that would have brought that number down massively, But I had read something like that as well, and I was like, ooh, that can't be it anymore. Yeah,
that's my goodness. Well,
thanks for looking that up. Thank you.
Yeah, no problem. But thank you so much for your presentation. I really, really enjoyed it. And one of my comments is, can you come to California? Because we need this. And in all seriousness, I really love the idea of having older women be that support, because I think it makes a lot of sense. Just from my experience, like, nothing phases them. And I say this while thinking of my own grandmother. She's gone through so much. She grew up in India, born and raised in a small, poor village, and then through circumstances was able to come to the United States and bring her 10 children. And right. So it's they really lived through so much. So I think it's really amazing. So I guess my question though is, and maybe you mentioned this and I just missed it, but why Zimbabwe? Like, was there a specific reason why that was the country that was kind of where you're based and where you're doing all this research in, or it just kind of happened? Or I'm really curious about that.
So my colleague, the founder of Friendship Bench, Dixon Chibanda, he is Zimbabwean. So it's just where he is. And at that time, he was the only psychiatrist in government. And it was basically after he did his prevalence research there for his Masters of Public Health, he was also told, well, it's nice that you have this prevalence now. What are you going to do? I joined a couple of years later, because, like, I'm originally from Europe and Siatko, and we just kind of end up living in Zimbabwe, right? So
that makes sense. Perfect. Thank you.
Yeah. Yeah, we're very, very happy to be here, and it's really interesting because we're like the only scaled up mental health program in sub-Saharan Africa, and we've gotten a lot of media coverage lately because we are evidence-based. So a lot of programs are happening, but nobody bothers to really go into research, which we totally understand, because research seems like, oh God, how does it work? How do you do research? And we somehow did it the other way around. We first did research, and then now we're like looking into, how do we do implementation? And yeah, so this year we're fully focusing on scaling up. And like I said, scaling up globally. So we'll definitely come to California sooner or later.
That's awesome. I was going to ask you as a last question here before we wrap up. You kind of touched on that a little bit, but what is next for the Friendship Bench? So you said scaling up, focusing more on implementation versus research. Tell us more.
So currently, we are negotiating with a few collaborators or potential partners, but we definitely are lined up for Liberia and Rwanda very, very soon. and actually Kenya, and South Africa and Vietnam, and so just, you can see, you know, it's almost it's wonderful, but it's also a little bit mind blowing, because our team here is still very, very small. So yeah, and we're mental health people. We've done research, but this implementation thing now is a new shoe that we're trying on, and we're trying to grow fast with it.
Nice. And what are some of the challenges that you're facing? What sort of needs do you still have as you grow and go on this expansion journey?
So I think, okay, what are challenges? So one challenge is, and that's why we like having you here, is just talking about that whole data collection and making that digital and making it easily accessible. And again, please, like everybody who listens, put it in the context of, we don't even have power all the time, like electricity, you know, so let alone do we always have network for cell phones, and people don't have computers, and so we need to come up with something that works like worldwide kind of thing, and is easy. And I think you had some great ideas there already. So that's something to put our mind in at the moment. And then just because we're community-based, we would like to work with countries. So we would like to work within like health systems as much as possible, because we really want to be there where the population is. We want the communities to be reached, and we want this to be working within the communities, so that it's not like all these people bring Friendship Bench in it, but it's communities who take it up and grow it the way they need to grow it, because obviously it has to be locally adapted. If just think of language, so that's the experience we had when we were in Zanzibar. We had to translate everything in Swahili and discuss and think, even if it's translated, it still didn't quite fit the cultural expressions, and same in Malawi as well. So I love that bit. It's so exciting to see how does it fit into the context, you know, and still work there, you know. So
awesome.
Yeah.
Well, exciting work ahead.
Yeah.
All right. So with that, I'd like to wrap us up for this recording. So thank you everyone for joining us for this week. And Ruth, I will hand it back to you in a moment. But before we do that, everybody that's watching this recording, please remember to indicate your attendance. So scroll down a bit more and fill out the attendance survey. Also, please complete the, or leave us a comment or question in the section at the very bottom of the page. Ask Ruth a question, or comment on anything else that you saw that intrigued you throughout the program page. And we hope to see you here again next week. And with that, let me just give it back to Ruth for a final word of wisdom.
Okay, thank you very much for inviting me, and thank you very much for listening, for having listened now or in future. And we're very excited. And I think the biggest words of wisdom here that I can say is that everybody should recognize they have a mental health and a mental health need, if not more than one, and that we all sort of learn to talk more openly to each other.
Perfect.
And just listen more to people. So yeah, thanks.
Great.
Okay, thank you.
Thanks so much, Ruth.